Okay. Thank you. I felt like that was also for me approaching the stage. I have a terrible fear of speaking, but in the same light, we really wanted to bring you this information. And I want to tell a little story before I start getting into the science behind it so that you all know where this came from. We had a number of people involved in this, and I don't want to leave them out. Amy and I are presenting, but we had other people that added their eyes to this project. A few years ago, we started talking more about MALS and what MALS is. And really, there was only surgery. And I was seeing patients in my clinic, and by that point, becoming an EDS specialist, I kind of had to prove myself too. So with over 15 years in orthopedics and athletic trainer, I had a lot of orthopedic background, but it was not serving me as a specialist anymore with the people that I was seeing. I was starting to get sent to patients that had tethered cord and CSF leaks, and my strategies were not working anymore. So by the time MALS came out, I was already in the visceral world. And I think Kimby talked a little bit about lymphatics and visceral work, and it really does work. So I'm really excited to present this, especially to our other providers, physicians, and MDs, so they can start to see we actually can move vasculature. I was in a brain course last week. We can actually move neurological tissue. We can move organs. We can do it. There's not many of us out there right now, but for those of us that have been doing it, we're actually having success with MALS. So as this started to come out, and we started to try to figure out what MALS is, and for those of us that knew anatomy knew that it was much more than a ligament, and that there was probably a lot that we could do because some of us were having success in the office. So I am part of the EDS ECHO program, and all the time I'm saying, hey guys, I have these ideas about tethered cord. I have these ideas about MALS. Does anybody want to hop on and just have a talk so that we can start talking about what is this? How can we help this non-surgically? So Amy was on one of those at one point and was just as excited as I was. I don't get that a lot, to be honest. And for the past year, we have been working on this. So Amy has flown herself out to Denver. We have had patients that you'll see have donated themselves and their wonderful bodies that have MALS-like presentations to this work. We had Ron Hruska of the Postural Restoration Institute, the founder, that flew out to look at our patients because he was so intrigued how symptomatic hypermobility would play a role in MALS. We also had Robin Fogg, who has presented. We had different eyeballs on this because if I came up here and told you what I saw, it is my opinion. I need somebody to tell me when it doesn't sound right, when we have better ideas. So this is just the start of it. So that's what I wanted to present is we are going to throw a lot of information at you, and it's really just a foundation so that our providers and our patients can start thinking. There's been a lot of information on the diaphragm already, so we're going to blow through that information, but just understand how important it will be when you understand what we did find. Okay. So we're gonna fly through this because I'm so thankful. We've already talked a little bit about MALS. It's this belt area pain. It can be compression of the neurological tissue or the vascular tissue in that area. There can be many things in our patients that we see. It's usually not one thing. It's actually usually quite a few, neurology and vasculature as well. But we're seeing a lot of these patients now with multiple vascular compressions. We'll come back to that. I am not going through all of these signs and symptoms of MALS, but I wanted you to see how much it can affect. We are compressing neurovascular structures that interplay with a lot of the body and our pressure regulations that happens through lymphatics and CSF, which we'll talk a little bit about too. We are probably not recognizing this as much. We talk about it much more now, so I don't trust the prevalence on this. It's underdiagnosed, it's misdiagnosed. We miss it for years, so I question if people really are being diagnosed at 30 to 50, or have we just missed it for a while? It does seem to be more females than males, but the interesting part, and this is where we wanted to see what the heck was going on, because when they looked at cadavers, 1/3 of the cadavers had this dysfunctional median arcuate ligament, and they did not have a diagnosis of MALS or report pain in that area. So the question is, why? So structure is only one factor. We're gonna skip this just because I have better information for you in a moment, but there is some testing that can be done. It's important to understand that negative testing does not always mean that the patient does not have a compression problem. Currently, we're only talking about surgery, so we want to change that a little bit, and we're not saying don't do surgery. We just want to give better options pre-surgically, and then most especially if surgery is done, that we have ideas pre and post for the best outcomes. And we don't really know what outcomes we have with our population because we don't know if we have the best surgical strategies quite yet. It depends on where they go. But this is the general population. They seem to be doing better if they had more post-exertional pain rather than pain after eating. And they also seem to maybe not get as better if they reported more of the vomiting and unprovoked pain, which we'll come back to with our population. So this study, I do believe it was Dr. Hakeem who sent it my way. Thank you. Amy and I did all this research for about a year, and we're like, I can't believe there's nothing out there. And when we submitted our slides, this was sent back, and I'm like, oh, well, at least it validates what we were working on, but we had no idea that this was actually out there. There is actually a study that looks at compression in those with symptomatic hypermobility. Please read it. It's wonderful. What I do want to say is that there does seem to be kind of this cluster of what we're seeing. It's not just vascular compression. If they have vascular compression and symptomatic hypermobility, there seems to be this gastrointestinal issues, psychiatric presentations. It's very layered, and there's probably multiple compression sites as well. So there's a lot more going on than probably a median arcuate ligament. So in this study, they looked what symptomatic hypermobility was doing, and I'll summarize this because I need Amy to show you all the amazing things that we found. But this belt area pain that people were having, it was compression that they were finding. Not only was it compression, but the majority of individuals had multiple sites of compression, 2, 3, 4 areas. So we're talking about that superior mesenteric artery, nutcracker syndrome, other areas that are in the abdominal space. If people had an issue with the surgery and they had a recurrence of symptoms afterwards, most everybody that they looked at had symptomatic hypermobility. So we probably have to do something a little bit different. When they looked at their whole population and looked to see who had hypermobility, again, when they looked at it, about 3/4 of these individuals had symptomatic hypermobility. So there is a correlation. What they recommend, I'm going to summarize this really quick, I apologize. Listen first for our providers. So when we're testing for it, when we're trying to figure out if somebody has it, you listen first. So some doctors are trained how to listen. Visceral vascular specialists, manual therapists, can actually also listen through their hands to feel what the flow is like. They do recommend, and I thought this was really interesting, I have patients that ask me all the time, especially when they have negative test studies. What is recommended through this paper is to have a functional ultrasound done. So put the patient into where they are symptomatic and do the Doppler ultrasound in that position. So this is the paper. Feel free to look it up and read it. What's interesting moving into the big part of our talk is that this hyperlordosis was found. So there's a change in the lumbar spine. And we're going to talk a little bit more about that, more in females than males, but there was a change. Also, when we're looking at those that had issues with the release of the median arcuate ligament, the females especially that had symptomatic hypermobility seem to have an issue with scar tissue. So they do recommend a full resection, but not really this talk. So I'm actually going to skip forward one, because I know this is the image that we do see a lot. We see the compression of the median arcuate ligament. It looks like it comes down over the celiac artery. But what we're going to go back to here is actually that median arcuate ligament is actually just, this little band here that is attached, this giant diaphragm that is attached to the spine that forms that crest around the aorta and all of those structures there. So that's why this is so important. So there's actually a lot that we can do. So we've already talked about the diaphragm moving a lot. It moves a lot. And this is where I'm going to have Amy take over in just a second. The diaphragm actually serves 3 roles in the human body. It is a respiratory muscle. It is a pressure pump regulator. Those are supposed to be autonomic. We're not supposed to be thinking about them. What it also does, though, it's a postural stabilizer. If we slip and fall, if we're going to grab something, it actually contracts as a postural stabilizer because it's connected to the lumbar spine. So if for any reason that diaphragm turns itself more constantly and consistently into a postural stabilizer, you will lose those other autonomic functions of a respiratory muscle and the pressure pump regulator. So pressure pump regulation, we could talk all day about this, but it is actually very important for movement of fluid. The 4 pressure systems are maintained together. We have air pressure, we have the blood pressure, we have lymph and cerebrospinal fluid, and if one of them is not working correctly, the others will try to actually compensate for that. So the mechanics of respiration that Amy's gonna come up and talk about is neurology, anatomy, and alignment. And that is what we really want everybody to take away on what MALS actually is, or this celiac compression problem that's happening in this belt area. So Amy, come on up.
All right, so our clinical assessment. Anatomy. I paused. Okay, but my notes aren't there. That's very odd. Okay, well, I'll go from memory. We'll see how you do. So first thing we're going to do is we're going to, in the clinic, first thing we're going to be assessing is anatomy. And that can be affected due to structural variations, trauma, or functional adaptations. Now, we went forward. I've skipped past the neurology slide by accident. Hold on, let me go back. There we go. Neurology. When we're assessing neurology, we need to make sure we're assessing for trauma, whether there's inflammation in the system, whether we have a change in our rib cage because of hypercapnia. We'll change the alignment of our rib cage and how our diaphragm is functioning. If there's a brainstem dysfunction, and sleep apnea. I think we all know how dangerous sleep apnea is and how that affects our nervous system. And then, let's go here. Anatomy. As I said, that can be affected by multiple things. And we had so many anatomical things that we wanted to speak about. We actually ended up putting it on 2 slides. And you'll notice that there's carryover from the neurology to the anatomy. We repeated some of those things because it was hard to discern whether we should put it on the anatomy side or the neurology slide. The one thing I want to point out on this slide is our abdominal weakness. When we want to assess abdominal weakness, we don't want to assess the ability of the patient to be able to do a sit-up. We want to be able to assess the ability of our obliques and our transversus abdominis to stabilize our trunk. And we also want to be able to have eccentric control of the rib cage during inhalation, because if we don't have that, our diaphragm can't function effectively, and then we don't get good pressure regulation or trunk stabilization. So we want to be assessing the alignment of the rib cage and the strength of the abdominals to determine the efficiency of the diaphragm. And then continuing with this, one other point that Patty already made is that we want to make sure that we're doing auscultation as well as palpation of the belt area, because if there's tenderness in that area, that's going to be indicative of a compression syndrome. And then we have other factors that were also on the neurology slides. So clinically, we may struggle to impact or assess accurately the neurology or even necessarily the anatomy without studies. However, alignment is a factor that we can have some significant impact on. And when we are assessing alignment, we need to ask ourselves 3 questions clinically. First, what's the posture? Second, what's the effect of gravity? And is there any torsion in the system? We need to be assessing our posture of our clients in all 3 planes. So we don't want to forget the transverse plane. We don't want to just look front and side. We want to be looking at all 3 planes. Our bodies and brains will accommodate to chronic posture. So if we're always holding ourselves in a specific posture, our brain learns that that's straight. And then we will utilize those postures, which facilitates torsions and will put tension on all of our tissues, and that will stress our ligaments, vascular, and nervous system. So this is an example. We have these 3 lovely people, as well as many others, donated their bodies to us so that we could take a look. And you'll notice you want to see that this person has flared ribs here, here, here. So rib cages, they are very flexible. They're supposed to expand and compress. They're supposed to move 360 when we're breathing. And assessing the alignment of the ribs, if we see something like this, we can pretty much be sure that there's some sort of faulty respiratory mechanics, and then that will give us a clue as to how we have to go further into our assessment. This is 2 of the people that we were looking at. If you notice here, this person has a torsion. Her upper trunk is rotated counterclockwise, and the lower portion of the pelvis is rotated clockwise, creating torsion in the system. This person here has a pressure regulation issue, uses the belly to breathe. The rib cage barely moves at all when he has respiration. These people, they thought they were straight. Okay, so when we were taking pictures, we're like, stand straight. So their faulty alignment is due to them hanging out on ligaments. It could be due to weakness. It could be to faulty proprioception or structural changes. But they're definitely putting a lot of pressure on their tissues. So once we help our clients find optimal alignment, we want to focus more on improving biomechanics. And we need to start with respiration, and then move on to the biomechanics of the rest of the body, including the girdle joints, which would be our shoulders and our hips. So this is, do I have to click on it to, yeah. So this is an example of one of the exams that we do. I'll remind everyone that our rib cage is meant to be very flexible. And when we do this assessment, we're very careful to make sure that we're just taking up the slack in the rib cage. Here we're assessing how much the upper rib cage moves. So you'll notice that he's going to try and inhale, and it's all going to happen in his belly, and nothing's going to happen on the right here. Oh. Hold on, let me go back. I apologize. Here. And you'll notice that there's no movement here when he inhales. Nothing's happening. And then on the other side, you'll take a look there and watch. He'll exhale. You'll notice his abdomen doesn't pooch out as much when he breathes, and you'll notice that there's some better filling on the left. I wouldn't say perfect, but he's getting some more movement on the top left-hand side. I'm not going to play the video on this one, but this is the position where Patty and I assess the filling of the back of the ribs. We have lungs back there, and you should see some movement of these ribs when people inhale, and if you don't, that typically means that they're using their necks to breathe. And we want to make sure that we're assessing hips and pelvis, because remember the diaphragm attaches into the lumbar spine. Our treatment paradigm. So we want to always make sure we're assessing neurology and anatomy, knowing that alignment is where we're going to be able to make our greatest impact, which will then trickle over to improving biomechanics. Understand you cannot have good biomechanics if you don't start with good alignment. You can't move well if you don't start in a good position. So these, Patty already touched on most of these. I'm going to touch on the last 2. So posture, girdle joint alignment, breathing mechanics, somatic exercises. So we've talked a lot about exercise, and somatic exercises are meant more to help people have better understanding of how it feels to be in good alignment and how it feels to have good respiration. And then the manual therapies that she mentioned here, definitely the visceral manipulation, working on the vascular system, the nervous system, getting the vagus nerve to move better. So this is an example of an exercise where we're teaching somatically for them to use their diaphragm better, using isometrics, and working on breathing. Here, we're going to modify the position and provide tactile cues to be able to not over pull up on the ribs, to be using too much of a neck strategy. In this example, we're facilitating breath through the upper back, and I'm cueing the abs to not have them pooch their belly as much and use their soft abdomen. Neurologically, we want to make sure we're assessing if all the other strategies that we're doing, we want to make referrals and use other modalities. Last slide, I think I did it. All right, our take-home message. The take-home message is that this is complicated, and we're just getting started and trying to figure it out. We don't have answers, we have more questions. We want you guys to be asking more questions and be more curious. Clearly, we need to be using more conservative treatment rather than going to surgery right away. And then if people are surgical, we want to make sure that we have a strategy for them afterwards to be more successful. Thank you.